The earliest signs of vitamin B12 deficiency are not dramatic. They do not send you to the emergency department. They do not stop you in your tracks or force a conversation with your doctor. What they do is something far more insidious. They settle into the background of your daily life, get absorbed into your baseline, and get explained away by everything except the thing that is actually causing them. A slight tiredness that you put down to a busy week. A forgetfulness that you attribute to distraction or age. A faint tingling in your fingers that you barely notice and quickly forget. A mood that has flattened slightly without obvious reason. Each of these, on its own, is easy to rationalize. None of them individually compels investigation. And that is precisely the biological trap that B12 deficiency sets, because these signs are not vague, they are not random. They are the specific, predictable output of a body in the earliest stages of a deficiency that, left unaddressed, will progress into something far harder to reverse. The critical word in this video's title is early. Not because these signs are trivial, they are not, but because the early stage is the stage that matters most. It is the stage where the nervous system can fully recover, where cognitive function can be completely restored, where the progression toward irreversible neurological damage can be stopped before it has meaningfully begun. What I see in emergency medicine are the patients who reach me at the late stage, and what they uniformly have in common is that the early signs were present, were noticed, and were not acted upon. Not because they were careless, because nobody had explained to them what those signs meant. That is what this video is for. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years in the AA and EE, I have developed a particular appreciation for the early stages of progressive conditions, for the window that exists before something correctable becomes something managed, and before something managed becomes something permanent. B12 deficiency is one of the clearest examples of that window I encounter in clinical practice. Caught early, the correction is simple, the recovery is complete, and the long-term consequences are zero. Caught late, you are working against damage that is already structural, damage to nerve fibers, to spinal cord tracts, to the metabolic environment of the brain, and the outcome is uncertain. My goal in building this channel is to give people the knowledge to act in that early window, to recognize what their body is communicating before the communication becomes urgent, and to understand that the signs I am going to describe today are not things to monitor passively over the coming months. They are things to investigate now. Before I go through the 8 early signs, I need to give you a brief foundation in what B12 actually does inside your body, because that understanding is what gives each sign its meaning. I promise to keep creating the most helpful videos I possibly can, grounded in science and the latest research to help you live longer and prevent the diseases I see every single day in emergency medicine. All I ask in return is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not think it was worth your time, or you have not learned something genuinely useful, feel free to unsubscribe, no hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from more than a decade in medicine. Please subscribe, and let us get into it. Understanding why B12 deficiency produces signs in the early stage before the anemia is severe, before the nerve damage is advanced, before the cognitive decline is obvious, requires understanding what B12 is doing at the subclinical level. Because the early signs are not the result of catastrophic biological failure, they are the result of systems beginning to operate below their optimal capacity. And that distinction matters because it explains why they are so easy to dismiss and why acting on them is so much more valuable than waiting for something more dramatic. B12 is a coenzyme, a molecule that enables other biochemical reactions to take place. It does not act alone. It functions as an essential partner in a set of reactions that touch 3 biological systems simultaneously: blood cell production, myelin maintenance, and methylation chemistry. When B12 begins to fall, these 3 systems do not fail suddenly. They degrade gradually, with the earliest signs appearing well before any of the 3 reaches a state of clinical crisis. The first system to understand is the methylation cycle, and this is where the earliest signs originate, because methylation is the most sensitive of the 3 systems to falling B12. Methylation is a fundamental biochemical process in which a methyl group, a simple carbon-hydrogen cluster, is transferred from one molecule to another. These transfers are happening constantly throughout the body, and they govern an extraordinary range of functions: DNA repair, neurotransmitter synthesis, gene expression regulation, inflammatory control, and the production of myelin. B12 is an essential cofactor in the key step of this cycle, the conversion of homocysteine back to methionine, which then feeds the production of S-adenosylmethionine, the body's universal methyl donor. When B12 begins to fall, this conversion slows. Homocysteine begins to accumulate. S-adenosylmethionine production declines, and the downstream effects of that slowdown begin to appear subtly across multiple systems before any single system has failed completely. The earliest cognitive and mood changes that appear in B12 deficiency originate here. Neurotransmitters, serotonin, dopamine, noradrenaline are synthesized through methylation-dependent reactions. When the methyl supply begins to tighten, neurotransmitter production begins to drop, not dramatically enough to produce a clinical psychiatric syndrome, but enough to change the texture of daily mental experience in ways that are real, functional, and measurable. A slight reduction in mental sharpness, a mood that is fractionally less resilient, a motivation that requires slightly more effort to access. These are the earliest neurochemical signs of a methylation cycle beginning to stall. The second system is myelin maintenance. Myelin, the fatty insulation around nerve fibers, requires constant biochemical renewal, driven by the same methylation reactions that produce neurotransmitters. In the early stage of deficiency, myelin is not visibly damaged. Nerve conduction studies may still be normal, but at the cellular level, the renewal process has begun to slow. Myelin is being maintained less efficiently than it was. Subclinical changes in nerve function begin to appear, most often as intermittent, mild, and easily dismissed sensory changes in the hands and feet, not pain, not significant numbness. A subtle alteration in sensation, a mild tingling, a fleeting pins and needles, a faint change in how surfaces feel that comes and goes and seems too minor to report. Research published in the journal Neurology has shown that measurable changes in peripheral nerve function appear at B12 levels that are still within the low normal reference range, well before any structural nerve damage is visible on diagnostic imaging. The early sensory signs are the nervous system communicating subclinical myelin stress. They are meaningful, they should not be ignored. The third system is red blood cell production. In the early stage, the bone marrow is compensating. The full picture of megaloblastic anemia, with significantly reduced hemoglobin and visible macrocytosis on a blood film, is not yet present, but the production of red blood cells is already beginning to become less efficient. Mean corpuscular volume, the measure of average red cell size, begins to increase subtly as the cells start to enlarge before the division failure becomes apparent. Hemoglobin may still be normal, but oxygen delivery efficiency is beginning to decline at the marginal level. The consequence is not dramatic fatigue, it is a slight reduction in energy ceiling, a mild effort intolerance, a recovery from exertion that takes fractionally longer than it used to. This is the earliest hematological sign, not anemia, but pre-anemia, the system degrading before the threshold that triggers clinical alarm has been crossed. And underneath all of this is the absorption question, the factor that makes early deficiency possible even in people with apparently adequate diets. B12 requires intrinsic factor, a carrier protein produced by stomach parietal cells to cross the intestinal wall into the bloodstream. As intrinsic factor production declines with age, with medication use, or with immune-mediated damage to parietal cells, less and less dietary B12 is being absorbed with each passing year. The liver stores are drawn upon to compensate. Those stores can last years, which is why the deficiency builds so slowly, and why the early signs appear so gradually and at such a remove from any obvious dietary change. A person whose intrinsic factor production began declining 5 years ago may only now be reaching a level where the early signs emerge. Their diet has not changed. Their awareness of a problem is zero. But the depletion has been running for years. That is the biology that produces the 8 early signs. Now let us look at each one and at why each one is the specific biological signal it is, rather than the random or coincidental discomfort it is so often taken to be. Just really quickly, if you are getting value from this so far, please consider hitting the subscribe button. It helps this channel reach more people who need this information. Here is the pattern that I find most striking in clinical practice, and the one that makes early B12 deficiency so consistently missed. Each of these 8 signs taken individually is common enough in the general population to be attributed to something else with complete plausibility. Tiredness is attributed to work, mood changes are attributed to stress, tingling is attributed to posture. And because each explanation is individually reasonable, the signs are never gathered together and read as a pattern. The mistake is not ignorance of any individual sign. The mistake is failing to recognize that several of them appearing together in the same person over the same period of time is not a coincidence. It is a signal. The first early sign is a subtle but persistent reduction in energy, not the profound disabling fatigue of advanced deficiency, but a noticeable lowering of what I would call the energy ceiling. Things that used to feel manageable begin to feel like they require more effort. A full day leaves the person more depleted than it used to. Recovery from physical or mental exertion takes longer. Sleep does not fully restore the baseline. This is pre-anemic B12 depletion, expressing itself at the hematological and mitochondrial level. Red blood cell efficiency is declining marginally. Cellular energy production is beginning to be impaired. The person is not anemic by conventional testing, which means routine bloods come back normal and the energy change is attributed to lifestyle, stress, or age. I have had patients describe this as feeling like they had been running on 90% for so long that they had forgotten what 100% felt like. That description, when I hear it in the context of other early signs, tells me exactly where to look. The second early sign is mood changes, specifically a flatness, a mild withdrawal, a subtle reduction in the emotional engagement with daily life, or a patience and resilience that has quietly shortened. Not a depressive episode in the clinical sense, not the sustained low mood, hopelessness, or functional impairment that meets diagnostic criteria, something quieter and harder to name. A slight narrowing of emotional range, an enjoyment that requires more effort to access, a tendency to feel mildly irritable without clear provocation. These changes emerge from the methylation slowdown I described earlier, specifically from a declining S-adenosylmethionine supply reducing the synthesis rate of serotonin and dopamine. The neurochemical shift is real, measurable, and reversible. But because the change is gradual and subtle, it tends to be interpreted as a personality shift, a response to circumstances, or simply the normal variation of mood over time. Research published in the Journal of Affective Disorders has identified early methylation impairment as a contributor to subsyndromal depressive symptoms, mood changes that do not meet the threshold for a clinical diagnosis, but that significantly affect the quality of daily experience. The third early sign is a mild difficulty with concentration and word retrieval, what most people describe colloquially as brain fog, but which is more specifically a slowing of processing speed and a slight unreliability in working memory. Words that used to come immediately take a moment longer. Names that should be easy to retrieve require an effortful search. The thread of a conversation or a task is slightly harder to hold. Reading the same paragraph twice before it registers, this is not memory failure in the dramatic sense. It is a subclinical cognitive shift driven by 2 parallel mechanisms, a gentle decline in cerebral oxygen efficiency as red blood cell quality begins to deteriorate, and a reduction in the methylation-dependent processes that maintain the metabolic health of the neurons themselves. At this stage, a formal cognitive assessment would likely be normal, but the person notices even if the tests do not catch it yet. The fourth early sign is a mild tingling, pins and needles, or altered sensation in the hands, fingers, feet, or toes, intermittent rather than constant, often noticed at rest or at the end of the day, and frequently so brief or mild that the person does not think it worth reporting. This is subclinical peripheral nerve demyelination expressing itself at the sensory level. The myelin renewal process has slowed just enough that the peripheral sensory nerves, the longest and most maintenance-dependent fibers in the body, are beginning to misfire intermittently. Signals from the nerve endings in the extremities are arriving at the brain slightly distorted or delayed, producing sensory noise that the brain interprets as tingling or altered sensation. At this stage, a nerve conduction study may still be normal, but the biological process that will eventually produce measurable nerve damage is already underway. This is the nervous system's earliest warning. It is quiet, it is intermittent, and in most people it is entirely ignored. The fifth early sign is a subtle change in skin or hair, specifically a pallor that is slightly more than what the person would consider their normal complex hair that is becoming slightly more brittle, or shedding marginally more than usual, or nails that are growing more slowly and becoming subtly more fragile. These changes reflect B12's role in cell turnover throughout the body. B12 is essential for the rapid division of cells in the skin, hair follicle, and nail matrix tissues that renew themselves on a continuous basis and that are among the first to show the downstream effects of a slowing methylation cycle. At the early stage, these changes are subtle enough to be attributed to season, to stress, to hormonal variation. They are rarely severe enough to constitute an obvious clinical finding. But in the context of the other signs in this list, they are part of a coherent pattern of a body whose cellular renewal is beginning to operate below its optimal capacity. The sixth early sign is a sore or slightly tender tongue, milder than the dramatic glossitis of advanced deficiency, but noticeable as an occasional burning sensation, a mild sensitivity to acidic or spicy foods that was not previously present, or a subtle awareness of the tongue surface that the person had not experienced before. The mucous membranes lining the mouth and tongue require rapid continuous cell renewal, a process that B12 supports through its role in DNA synthesis. In the early stage, this renewal slows imperceptibly, and the first thing many people notice is a tongue that feels mildly more sensitive than usual. Not painful, not visibly inflamed, not the smooth, glossy surface of significant deficiency, just slightly off, slightly more aware of itself than it used to be. I want to be clear that this sign is non-specific on its own. Many things can cause mouth sensitivity, but together with the other early signs, it points toward a body-wide slowdown in cell renewal that has a single most probable nutritional driver. The seventh early sign is sleep that is less restorative than it used to be, a pattern of waking that does not feel refreshed, of lying in for longer and achieving less, of sleep that is present in hours but absent in quality. B12's role in the synthesis of melatonin, the hormone that regulates the sleep-wake cycle, involves the same methylation pathways that govern neurotransmitter production. When methylation slows, melatonin synthesis can be subtly impaired. The consequence is a sleep architecture that is shallower, less restorative, and more easily disrupted. This is often experienced as difficulty getting to sleep, or difficulty returning to sleep after waking in the early hours. In the early stage, it rarely meets the threshold for insomnia. It is simply a sleep that has become less efficient, without obvious cause, and which is almost universally attributed to stress, screen use, or the pressures of modern life, rather than to the single biochemical factor that could be driving it. The eighth early sign is a very mild shortness of breath or an awareness of the heartbeat during activities that should present no challenge at all. Walking upstairs at a normal pace, carrying bags from one room to another, a short walk at moderate speed. Not breathlessness that stops the person in their tracks, a subtle awareness of the breath that was not previously present, or a heartbeat that is just slightly more perceptible than before. This is the earliest hematological sign at the cardiovascular level, preanemia beginning to reduce the oxygen delivery efficiency of the blood just enough that the cardiovascular system has to work fractionally harder during mild exertion. Resting at this stage will show nothing abnormal. A routine exercise tolerance test would likely be normal. But the person notices something has shifted, a marginal reduction in the ease of mild physical effort that they attribute to fitness declining with age or a period of inactivity. It is neither. It is the earliest expression of red blood cell dysfunction beginning to reduce the efficiency of the body's oxygen transport system. I want to be direct about something before I go through the practical steps. The value of recognizing early signs is that early action is categorically more effective than late action. The solutions I am going to describe are straightforward, the tests are accessible, the treatments where needed are well established. What makes them matter so much at this stage, compared to the stage of significant neurological involvement or severe anemia, is that at this stage, full recovery is the expected outcome. Not partial recovery, not managed deficit, full restoration of function. That is the clinical reward for acting in this window. The first step is getting the right investigation and understanding what you are looking at when the results come back. Ask your doctor for serum B12, serum methylmalonic acid, and serum homocysteine as a combined panel. At the early stage of deficiency, serum B12 alone will frequently appear normal or low normal, while the functional markers methylmalonic acid and homocysteine are already elevated, indicating that tissue level B12 is insufficient even before the serum level has crossed the threshold that triggers clinical concern. Research published in the New England Journal of Medicine established that elevated methylmalonic acid is the most sensitive available marker of true B12 insufficiency. Appearing before serum B12 has fallen to levels most laboratories would flag as deficient. If your serum B12 is below 400 picograms per milliliter and any of the early signs in this video resonate with your experience, methylmalonic acid and homocysteine are not optional extras. They are the difference between an investigation that can catch this early and one that cannot. The second step is identifying whether your risk profile makes early deficiency more probable, because understanding your risk shapes how urgently you act. Are you over 50? Intrinsic factor production declines with age, and B12 deficiency becomes substantially more prevalent after this threshold, regardless of dietary intake. Are you on a proton pump inhibitor for reflux or gastric protection? Long-term PPI use suppresses gastric acid to a degree that meaningfully impairs B12 absorption, and this is rarely monitored. Are you taking metformin for type 2 diabetes or prediabetes? Research published in the British Medical Journal has established that long-term metformin use is associated with B12 depletion in a substantial proportion of patients, and routine monitoring is not standard practice in most clinical settings. Are you following a fully plant-based diet without consistent supplementation? Dietary B12 exists only in animal products, and without supplementation, plant-based diets will eventually produce depletion regardless of how nutrient-dense they otherwise are. Any one of these risk factors substantially increases the probability that the early signs in this video have a B12 driver. The third step is understanding the difference between correction and supplementation, because they are not the same thing. If your deficiency is mild and your absorption is intact, dietary optimization combined with oral supplementation at 1000 micrograms daily is a reasonable and effective approach. At that dose, passive absorption, which requires no intrinsic factor, delivers enough B12 to correct mild early deficiency in most people over a period of weeks to months. If your deficiency is driven by impaired absorption, by reduced intrinsic factor production, by PPI use, by pernicious anemia, then the dose and route of supplementation need to match the absorption problem. High-dose oral supplementation remains viable for many people even with partial absorption impairment, because passive absorption is dose-dependent. But in confirmed pernicious anemia or significant gastric atrophy, intramuscular injections may be the most reliable route. This is a conversation for your doctor, not a decision to make unilaterally. What matters is that the treatment is proportionate to the cause, and that the cause is identified rather than assumed. The fourth step is dietary context, as a supporting strategy, not a primary treatment where absorption is compromised. The richest dietary sources of B12 are animal organ meats, particularly liver and kidney, which contain B12 concentrations that are orders of magnitude higher than muscle meat. Oily fish, eggs, beef, and dairy all provide meaningful amounts. For people following plant-based diets, fortified foods, specific plant milks, certain breakfast cereals, nutritional yeast provide some B12, but the amounts are generally insufficient to correct a deficiency without supplementation alongside them. I am not suggesting dietary change is sufficient treatment, but in the context of early mild deficiency where absorption is intact, dietary richness in B12 sources is a meaningful contribution to a recovery strategy that also includes appropriate supplementation. The fifth step is follow-up at 3 months after beginning any intervention. Retest B12, methylmalonic acid and homocysteine to confirm the functional markers are moving in the right direction. Ask yourself and document your answers whether the early signs have shifted. Is the energy ceiling higher? Is concentration clearer? Is the tingling less frequent? Is mood more stable? Is sleep more restorative? These subjective markers, tracked honestly, are valuable clinical data. If improvement is not occurring within 3 months, the dose, the route of supplementation, or the underlying cause needs to be reassessed. Early deficiency, treated appropriately, should show clear evidence of improvement within this time frame. In clinical medicine, there is a concept called the pre-symptomatic window, the period during which a disease process is underway but has not yet produced the symptoms that trigger investigation and treatment. For most serious conditions, that window is either invisible or inaccessible. We cannot see it passing. We cannot act in it because we do not know it is there. B12 deficiency is unusual in that its pre-severe symptomatic window is long, its early signs are real and recognizable, and its treatment in that window is both simple and highly effective. What I find most compelling about the research in this area is how clearly it establishes the difference that timing makes. A study published in the journal Practical Neurology, examining outcomes in patients with B12-related neurological involvement, found that those who were treated within 6 months of symptom onset achieved near-complete neurological recovery in the majority of cases. Those treated after 12 months or more showed substantially less complete recovery, with a meaningful proportion retaining some degree of permanent neurological deficit. 6 months is not a long time. It is the gap between one GP appointment and the next in many cases. It is the period during which most people are still attributing their symptoms to something they can explain away. I have had patients come back to clinic 3 months after starting B12 correction, patients who had been living with these early signs for over a year without connecting them to a cause, and describe what I can only call a recalibration, not a dramatic transformation. A gradual return to a baseline they had forgotten was possible. The energy that used to be available without effort, the thinking that felt sharper and more reliable, the sleep that left them actually refreshed, the tingling that had simply stopped. These are not dramatic clinical outcomes. They are the restoration of a normal biological state that the person had adapted to living without, so gradually that they had ceased to recognize how much had shifted. That recalibration is available to anyone whose deficiency is caught in the early stage. It is not available in the same form to everyone whose deficiency is caught at the stage of significant neurological involvement. The biology is honest about that asymmetry, and the only variable that determines which group a person falls into is when the question gets asked. The 8 early signs I have described today are the body asking the question for you. Not loudly, not dramatically. With the quiet, persistent, easy to ignore language of a system operating just below its optimal level. A slight reduction in energy, a mood fractionally less engaged, a concentration that requires a little more effort, a tingling too brief to report, a sleep that restores a little less, a tongue a little more sensitive, a hair and skin a little more fragile, a breath a little more noticeable on the stairs. None of them alone demands immediate action. Together, in the same person, over the same period, they are a pattern. And patterns in medicine and in biology have causes. The cause here is identifiable, testable, and correctable. The window to act in is open right now. If you found this useful, please subscribe to the channel to help me reach more people like you.